So I thought of meningeal carcinomatosis I'd like to also cover just briefly, but targeted therapies have been around more than a decade, and we've made a lot of progress kind of inching forward one target at a time with often very big benefits. There were a few studies, nothing huge, but studies in BRAF as a target, RET, MET, exon 14. So we may have, as broader molecular testing is done, it may lead to a marked increase in the number of patients known to have not just targets we know have therapies, but targets that are being studied, but potentially in a very limited way. Janet, can you talk about the potential for online connections to facilitate clinical research for potentially subsets of patients or even larger? But I'm especially intrigued by the idea of having the online community be able to help facilitate research on molecular subgroups that might otherwise not be feasible to study otherwise.
Yes, there are groups that are forming online. We have a group that's ROS1 across cancers. I know there's groups for ALK, there's groups for EGFR, and as the other ones get identified, I'm sure they'll form groups too. And we keep each other informed of where the trials are and the status of them, and if there's more than one approved drug, the order you might want to try them in. Because that information is moving so fast it doesn't always get out in the literature. We find it out from our doctors who are researchers in the area, and then we share it with each other.
Just to interrupt, I mean, it's really quite striking that often if you're a patient with a ROS1 rearrangement or some other rare tumor, you often are sharing information online, and so up to date that you can know more not only than the general oncologist, which shouldn't be surprising because of course they might have one patient with this rare mutation in a year or less, but often more than many other lung cancer specialists, because we're not dedicating the same amount of time to study this.
Well, if I may share a story
Please.
Briefly. Don Stranathan, and I have permission to share this story. Don Stranathan, who's a patient that had been stable 6 years on Tarceva, even though he didn't have the EGFR mutation. And he started to progress, and he had a Foundation 1 panel and came back with an NTRK1 alteration. And he'd seen that from the report that crizotinib seemed to work for some NTRK1 patients, and since that's an over-the-counter drug, not over the counter, but he could use it, sorry.
Not at Walgreens,
but he can use it off-label. He decided to try that first before exploring clinical trials. Well, he's on Facebook, and he happened to post on Facebook about his decision and his status because he knew that he had a lot of friends out there talking to people. He happened to post it on Facebook the day that I was about to go in and talk to Bob Doble at the University of Colorado, who was one of the co-authors on the first paper on NTRK and lung cancer. And when I told Bob Doble about it, he says, have Don call me, because Bob had been getting reports from oncologists that crizotinib was not working for NTRK1 patients. This isn't in any of the literature. And so after talking with Bob and some other oncologists, Don decided, he considered some clinical trials and then decided to go on Nivo, and he's stable again.
Well, there's certainly a potential.
People.
There have been groups like the LifeRaft group that does GI stromal tumors. They have that, and they've really promoted a lot of the research from within the community. And I think there is a potential, especially for the rare mutations, for patients to kind of self-aggregate, make themselves available for trials, and get studies done that might never be done otherwise.
So part of what we need to advocate for is getting more patients to get tested so that they know what their options are. While not all patients will have the option to travel to a clinical trial, some will, but they won't if they don't know that they have the mutation.